Although abdominal pain is a common presentation, typically patients don't present with this as their only symptom. And in this presentation, we're going to take a look at the other likely symptoms that patients are going to present with, along with abdominal pain. Patients who present with acute or chronic abdominal pain can present with a number of symptoms, and sometimes this can be quite numerous. Typically, you'll see patients present with abdominal pain that's accompanied by nausea, perhaps vomiting as well as dysphagia, trouble swallowing. As a result of these symptoms, they might also have a change in bowel function that could be accompanied by diarrhea or constipation. Abdominal pain is very rarely the sole symptom, and you're going to want to dig deep into other symptoms that the patient might be experiencing that can give you a clue to the underlying disease that the patient's experiencing. In abdominal pains, nausea is probably one of the most common presentations. Nausea is the sensation of feeling sick and be quite unpleasant for your patient. A good question to start with your patient is, how's your appetite? And this can give you indications of the indigestion that they might be experiencing, the accompanied nausea. And the important thing about nausea is we have to check that if it's just the sensation of feeling sick or if they've vomited at the same time. The sensation of nausea, vomiting, accompanied by indigestion can cause your patient to have anorexia and not be eating. And it's important to establish when your patient's last ate. Remember that nausea can be associated with a wide range of conditions and diseases, ranging from pregnancy to endocrine conditions such as diabetic ketoacidosis and adrenal insufficiency, hypercalcemia, liver disease, emotional states, or even adverse drug reactions. The important thing to think about in your patient who's had nausea and vomiting is, are they dehydrated and are they at risk of an electrolyte imbalance? Anorexia, or the feeling of not eating or wanting to eat, is important to explore. And from this, you're going to want to establish, is it a fear of food that may cause discomfort or feelings of indigestion? Or is it essentially avoiding food altogether in the fear of body image? So on top of this, we should be considering also mental health, anorexia, and bulimia as conditions that could be associated with nausea, vomiting, and the subsequent anorexia. Vomiting is another common symptom that you'll come into contact with patients who present with abdominal disease. An important point about vomiting is distinguishing between retching and vomiting. Remember, vomiting is actually involuntary, and it's the spasm of the stomach and the diaphragm and the esophagus that then culminates in the vomiting. An important distinguishing factor with your patient is that, are they retching or are they actually physically vomiting? When inquiring with your patient, it's also good to inquire about the colour and the quantity. Remember that normal gastric juice is clear and mucoid, but sometimes small amounts of bile are normal. We'd especially want to know if the vomit is brown or blackish, often described as coffee ground, which would suggest blood altered by the GI acid, which could lead us to a diagnosis of varices, tears, or peptic ulcer disease. Accompanying this, we'd also want to know about odour in terms of fecal vomiting as well, and this could indicate that our patient has a small bowel obstruction. Another thing that we want to consider with the patient who's been vomiting for some time is an electrolyte imbalance. And remember that sometimes an electrolyte imbalance can actually precipitate and make vomiting worse by making the patient experience feelings of nausea. So always consider in your patient that's been vomiting for some time that they might be dehydrated and have a resulting electrolyte imbalance. Sometimes with patients, vomiting and regurgitation can be confused, and it's important that we establish which is happening. Remember that vomiting will normally be preceded by retching, whereas with regurgitation, there will be no retching, and food will simply appear in the mouth or the throats. This can be as a result of gastroesophageal reflux disease, a stricture, but also by esophageal CA, and as well as pharyngeal pouches. So an important screening in your patient who is vomiting is asking them if they've been retching and vomiting, or if food or stomach contents has just suddenly appeared in the back of their throat without retching. And that should help you distinguish between vomiting and regurgitation. Dysphagia, trouble swallowing, or painful swallowing is also a symptom that you could come into contact with when dealing with patients who have abdominal complaints. Patients will often describe that food sticks or just simply doesn't go down right. Other symptoms that you could explore with the patient who complains of dysphagia would be drooling, nasopharyngeal regurgitation, where the food comes back through the pharynx and then the nasopharynx, and also coughing from aspiration, i.e. the food's going down the wrong way. And an important factor about distinguishing dysphagia is whether it's motility or whether it's structural. And if we look at a motility problem, typically these are associated with neurological issues, whereas if it's structural, typically it's a muscular issue. Generally, if you have a younger adult, It's normally going to be a mechanical or obstructive problem that they can't swallow. Whereas if you have an older adult who's complaining of food not going down right, you should think more neurological or muscular disorder, and this would be something like a stroke or Parkinson's disease. It's important that we try and distinguish from a globus sensation. And remember, a globus sensation is the feeling of a lump or a foreign body, but not necessarily having trouble with swallowing food. We should also inquire what type of food the patient has trouble swallowing, whether it's solid, liquid, or both. If your patient struggles swallowing solid food, this normally suggests a structural problem, whereas liquid or both could suggest a neurological or motility disorder. And then finally, if your patient's experiencing pain, always consider it could be a medication such as aspirin or non-steroidal that's caused an ulcer and therefore pain when the patient's trying to swallow. And you may also consider infections such as a candida infection or a herpes simplex or HIV infection. The important points about this history is establishing whether it's truly difficulty swallowing with the food not going down right, or whether it's the sensation of something in the throat. Changes in bowel function are quite common with abdominal complaints, especially if the complaint is regarding the intestines, stomach, colon, or rectum. The important thing about this symptom is recognizing that it's also a red flag for more sinister disease pathologies. A good question to start out with is, how are your bowel movements? And from this, we try to establish the frequency, and this is normally per week. Remember that frequency is broad and can be as low as 3 bowel movements per week, but establishing if they're going less than that or more is important in the history taking. And remember, you'd also want to explore difficulties that the patient has in terms of pain or inability to go, and also the appearance of the stool as well, whether it's watery or solid. Over the next few slides, we're going to take a look at these changes in bowel function in a little bit more detail. For patients presenting with a change in bowel habit, sometimes diarrhea is top of the list. Remember that diarrhea is described as painless, and often loose and watery stools accompany it. The important point about diarrhea is that we are trying to establish the timeline to define if it is acute or chronic. And for this, we need to think about if it's happened more than 75% of the defecations for 3 months, we'd define this as a chronic diarrhea. Whereas if it's happened over 24 hours with an increase in volume, we would describe this as an acute. The duration is also important, and we would describe diarrhea as acute if it's happened over 2 weeks, whereas chronic would be considered over 4. Remember that acute diarrhea is often associated with infection, whereas chronic is typically non-infectious in origin, and we can think of something like Crohn's disease or ulcerative colitis or a malabsorption condition as the culprit. We also want to establish if this is high volume and high frequency or low. High volume diarrhea normally originates from the small intestine, whereas small volume is normally associated with rectal inflammatory diseases. And for this, we should be asking about mucus, pus, or blood. The time of day that it also occurs is really important, and our red flag here is that we want to know if this is nocturnal. Nocturnal diarrhea is usually a bad sign, and if a patient's experiencing this, we should be thinking about a gastric CA. We'd also want to inquire about the consistency of the diarrhea and whether it's oily, greasy, or floats. And this is important because these are distinguishing factors for a malabsorption syndrome. And it's quite logical to think that if it is oily, greasy, or floating, the fats haven't been digested, and therefore we can think that there is a malabsorption syndrome. And finally, we also want to consider, is the patient taking any culprit medications that could cause diarrhea in the first place? So always inquire about penicillin, magnesium base acids, metformin, or perhaps your patient might have a C. diff infection if there'd been a recent admission to hospital. At the other end of the spectrum from diarrhea would be constipation, and this is another common presentation in both primary and secondary care. The Rome 4 category to diagnose a patient with constipation is that it should be present for at least 3 months and be causing less than 3 bowel movements per week. 25% of these should be with straining, and that's why we always inquire about the frequency and any associated symptoms such as straining. Or if these are incomplete and your patient might actually feel like they haven't completely finished going to toilet, or may have a sensation there's still stool within the rectum. Typically, they'll describe the feces as lumpy or hard, and sometimes even need manual facilitation to actually remove stool from the rectum. The important distinguishing factor here for us is the primary and secondary causes. Primary is often called functional constipation, and we can divide these into normal transit, slow transit, but also impaired expulsion, perhaps from pelvic floor disorders. Normal transit and slow transit in primary constipation are normally caused by something like irritable bowel syndrome. Secondary causes can include things like medications or conditions such as amyloidosis, diabetes, or central nervous disorders as well. An important point for us often in secondary care is the patient passing wind? Knowing this is really important because if your patient is constipated and has been for a number of days and is not passing wind, you're most likely dealing with a bowel obstruction.